In this session, I will review testing strategies and practical considerations for PD-L1 testing in metastatic triple-negative breast cancer, including why we test PD-L1, how we test PD-L1, and what specimens are suitable for testing. As we know, triple-negative breast cancer is characterized by high-grade histology, aggressive clinical course, and high risk of recurrence and limited options of targeted therapeutic options. It is an immunogenic subtype, often exhibiting abundant tumor-infiltrating lymphocytes, making it a suitable candidate for immune therapy. PD-1, PD-L1 interaction suppresses T-cell-mediated anti-tumor immunity. Immune checkpoint inhibitors block this interaction, restoring T-cell activity against tumor cells. PD-L1 expression is therefore a predictive biomarker for response to immune checkpoint inhibitors. The KEYNOTE-355 study established pembrolizumab plus chemotherapy as the standard first-line treatment for PD-L1 positive metastatic triple-negative breast cancer, with significant improvements in progression-free survival and overall survival. Recent study demonstrated that sacituzumab govitecan plus pembrolizumab significantly improved progression-free survival versus chemo plus pembro and in patients with PD-L1 positive metastatic triple-negative breast cancer. It's now an additional first-line option for PD-L1 positive metastatic triple-negative breast cancer. PD-L1 expression in triple-negative breast cancer is heterogeneous. Here are examples of triple-negative breast cancer from different patients. Both exhibit high-grade histology. When we do PD-L1 testing, one is PD-L1 negative on the left, and the other one is PD-L1 positive on the right. In KEYNOTE-355, about 38% of the patients had PD-L1 positive triple-negative breast cancer. The NCCN guideline recommended PD-L1 testing for all patients with newly diagnosed metastatic triple-negative breast cancer before first-line therapy. So how do we test PD-L1? Different immune checkpoint inhibitors have different companion diagnostic assays. Each assay was developed and clinically validated for a specific therapeutic agent. These assays differ in antibody reagent, staining platform, and scoring algorithm, and therefore the assays are not interchangeable. PD-L1 22C3 is the FDA-approved companion diagnostic assay for pembrolizumab, and the previously approved indication for atezolizumab in metastatic triple-negative breast cancer have been withdrawn in the United States. PD-L1 22C3 is scored using the combined positive score, or CPS, that is calculated from the PD-L1 staining cells that includes tumor cells and immune cells divided by the total number of viable tumor cells multiplied by 100. The positivity definition is CPS score 10 or higher. For those performing the actual PD-L1 scoring, there are several important details to keep in mind, especially when we score tumor cells, only membranous PD-L1 staining is scored. In contrast, in tumor-infiltrating immune cells, which is also included in the CPS score calculation, both membranous and cytoplasmic staining within the tumor area are included, so the criteria are different. It's also important to be aware that necrotic area are excluded from evaluation. For example, in this case, PD-L1 staining is confined exclusively to the necrotic area, with no staining observed in the viable tumor area. Therefore, even there's some staining on the slide, this case is interpreted as PD-L1 negative. So these are case examples demonstrating the range of PD-L1 expression in different triple-negative breast cancers, ranging from no staining to some staining with CPS score less than 10, and some staining with CPS score 10 or higher. And in some cases, the staining pattern can be rather diffuse. The previously used PD-L1 SP142 assay based on immune cell scoring was the companion diagnostic assay for atezolizumab. PD-L1 immune cell score is the percentage of tumor area occupied by PD-L1 positive immune cells that includes lymphocytes, macrophages, dendritic cells, with positivity definition as immune cell score 1% or higher. It's important to keep in mind tumor cell staining in this assay is not included. 22C3 and SP142 are distinct PD-L1 assays with differences in antibody reagents, staining platform, scoring algorithm, and clinical implication. The SP142 assay is less sensitive for tumor cell staining than 22C3. SP142 is specifically designed to evaluate immune cell PD-L1 expression. This is from our validation study. We compared different commercially available PD-L1 assays, stained the same tumor sample, and found differences in staining pattern and sensitivity. Therefore, the assays are not interchangeable. We also found 22C3 and SP263 seems to be more concordant, but not identical. So if a laboratory uses a different PD-L1 assay, different from the companion diagnostic assay, it must be validated to ensure assay accuracy. Specimen requirements. PD-L1 testing can be performed on either core biopsy or surgical resection, can be from either primary or metastatic tumor samples. Pre-analytical requirements are the same as for ER, PR, and HER2 per ASCO CAP guideline recommendations. In terms of sample adequacy, a minimum of 100 viable tumor cells is considered adequate for PD-L1 22C3 evaluation. Cytology specimens and decalcified bone specimens are not suitable for PD-L1 testing. Cytology specimens do not have the tissue architecture or the tumor microenvironment needed for a CPS score. Decalcification can reduce PD-L1 staining, leading to false negatives. Both specimens are not validated for PD-L1 testing per the manufacturer's protocol. PD-L1 expression shows spatial, temporal, and site-specific heterogeneity varying within the tumor over time with treatment and across metastatic sites. PD-L1 positivity rate seems to be higher in the primary tumor than in matched distant metastasis. For example, this is from our study. This is an example of PD-L1 concordant positive in both the primary tumor and in the matched distant metastasis. And in contrast, this is an example of PD-L1 discordant is positive in the primary tumor sample and negative in the distant metastasis. So either primary or metastatic tissue can be used for PD-L1 testing. Metastatic tumor samples reflects current disease status, but demonstrates lower positivity rates than primary tumor samples. Testing multiple specimens could increase likelihood of identifying PD-L1 positive patients. In summary, it's recommended to test all newly diagnosed metastatic triple-negative breast cancer for PD-L1 testing using the validated companion diagnostic assay for the intended therapy. And at our center, we prospectively testing PD-L1 in all metastatic triple-negative breast cancer samples. PD-L1 testing is not indicated for early stage triple negative breast cancer in the neoadjuvant setting.